I didn't get in this business looking at POTS, and indeed POTS was not described until the early 1990s. What I began in this business looking at was people with syncope. And syncope, just so we all have the same definition, we define as the transient loss of consciousness with spontaneous recovery. It comes from, in English, it comes from the Greek word syncopa, which means to cut short. Now, to give you an idea of how many people this affects, according to the Center for Disease Control, there's about 300,000 ER visits every year for syncope, and anywhere between 75,000 and 100,000 hospital admissions per year for patients suffering with syncope. Now, oftentimes as an electrophysiologist, some of the patients I see have life-threatening heart rhythm problems. Frequently, I see people with severe heart problems that syncope is the only sign they have before they have death. But at the same time, I became very aware back 27 years ago or 28 years ago when I began to do this, that there were people who the causes were somewhat more benign, but it nonetheless greatly disrupted their life. This is a painting from the parent of a woman from New York City who wanted to convey how she would find her daughter, basically just laying on the floor. And it became apparent also that it's, it wasn't so much the syncopal episode, but the consequence of it. You may not know this, but when Jon Stewart did The Daily Show, he basically copied it from Will Rogers' show that was on the radio. And actually, he says that he studied Will Rogers' shows in detail when he was making up The Daily Show. So it wasn't the first time somebody had that. This is the wife of a CT surgeon. After one syncopal event, she was doing the dishes. She suddenly lost consciousness, woke up in an ambulance, and had broken her jaw, and also had, you can't tell it from the photo, but it's called a blowout fracture. If you feel here, this is called the zygomatic arch around under where your eye is, and it was crushed and had to be rebuilt. This is a young woman from California who passed out suddenly, went down 2 flights of concrete stairs at her school, broke both arms and her face. This is a student who was actually from California and attending our university, passed out. This is a fracture a person suffered. I've highlighted it there after a syncopal event. So to give you an idea of how the system works or doesn't work, when a normal individual stands, gravity will attempt to displace roughly about 1/3 of your body's blood volume to the lower half of your body. That translates to anywhere between 500 and 700 cc's of blood, and that displacement is almost immediate. It is compensated for by an increase in heart rate, an increase in the force of your heart's contraction, and at the same time, by a tremendous increase, almost a threefold increase in the tightness of the blood vessels in the lower extremities. So everything from here down tightens. Now, how does the brain know what's going on? Well, it does so, and I'll show you in a second, by measuring stretch upon blood vessels through special unmyelinated C fibers called mechanoreceptors. So when you stand, gravity pulls blood downward. The brain senses this. It then compensates by increasing heart rate, increasing the force of your heart's contraction, and by tightening the vasculature from here down. And it does it all like that. So you can jump out of bed, jump out of a chair, do double backflips, and your pressure will all stay the same. Once you're upright, you must maintain this. Otherwise, gravity wins, you lose. And more of your blood volume will be displaced downward. Well, the more that's down here, the less can be up here. And how you feel will depend upon the degree and how quickly the displacement occurs. Small amount of displacement, you'll feel tired. You'll feel like tired. A little more, you'll feel like you can't think, can't focus, can't concentrate. More still, you'll start to get lightheaded, dizzy. More still, you'll see black spots, get tunnel vision, and more still, you'll pass out. Now, a backup mechanism that is unique to us humans, because we're the only truly two-legged critters on the planet, because even monkeys spend most of their time on all fours and only occasionally stand, is we have two things. We have a well-developed venous valve system within our large veins that tries to help prevent blood from leaking backward. Plus, we have a mechanism called the skeletal muscle pump, and what that refers to is contraction of the leg muscles and to a lesser extent the abdominal and arm muscles, compress the venous system and propel blood back to the heart. So a nice healthy set of legs can raise your pressure 10 points or more. People with poor autonomic tone are heavily dependent on the skeletal muscle pump, whether they know it or not. They learn compensatory activities, and they don't like to stand still. They like to keep moving, and they like to keep this activated. And even from childhood, we now estimate that about 10% of people have poor autonomic tone and just learn good ways to compensate for it. So in the mid-1980s, Dr. Richard Sutton and Dr. Rose Kenny at the Westminster Hospital in London got the idea that you could provoke periods of decompensation by inhibiting the skeletal muscle pump. Now you have to realize that no one had actually observed many of these episodes of syncope as they were occurring. We would only hear about them afterward, and people postulated all kind of things. And you can say anything you want as long as no one ever looks. So they got the idea that they could put someone on a table, incline them to about 60 to 70 degrees, and if they were cooperative during this passive tilt, the only stress on them was gravity. And what would happen is that they could inhibit the skeletal muscle pump, take away their backup system, and provoke them to pass out. And indeed, their research, published first in 1986 in the journal Lancet, showed that it was possible to do that. So suddenly, not only did we have a diagnostic tool, but for the first time, we could actually measure what was happening during an event. We could do echocardiograms, electroencephalograms, transthoracic impedance, blood draws for various levels, abdominal impedance, sympathetic nerve traffic. So we could watch events as they occurred, and what we saw is most of what we thought we knew was wrong. Now, as I mentioned to you, this, the way your brain knows what's going on is it measures stretch on these special fibers called mechanoreceptors. And these line every blood vessel in the body. They are concentrated in the posterior aspects of the right and left ventricle. They also are in the aorta and the carotid bodies, but they're everywhere. And when they're stretched, they give off more electrical activity, which then is referred to the brain. The brain processes this information. It then sends out instructions of what to do. It says, raise this, lower that, change this, change that. And then there's a feedback loop that occurs. So there's input, processing, output, feedback. And one of the things you have to realize when you're looking at autonomic disorders is any place along this pathway can be disrupted and give you a failure of the system to work, much like any computer system we have today. So it is not a single entity, but can be a multitude of different ways the system can be disrupted. Now this is the tracing from the second tilt we did in 1988. This was a woman who was a nurse at a local hospital. She was fired because she kept passing out, and had the $1 million workup circa 1988, and was told what we tell everybody when we don't know what's wrong with them: you must be crazy. At the time, this was a research test. She was referred to us, and then a few minutes into the tilt, she suddenly said, I think I'm going to, and I remember she never finished the sentence, and you can see both her systolic and diastolic blood pressure as well as her heart rate went to 0. And she began to have convulsive activity and then urinated all over herself, and my nurse and I were standing there with our mouths open saying, wow, that's pretty cool. But we decided we better put her down, and notice she has a rebound. Notice her blood pressure when we put her flat rebounds, so that we've seen this phenomenon oftentimes. So if you would have found her on the floor and measured her blood pressure at this point, it would have been very high. So we've seen this rebound effect, and this happens in a lot of other things. So for example, in a diabetic, following a period of hypoglycemia, when their blood sugar drops to 0, they will have a period of hyperglycemia. It's called the Somogyi effect. So when you find them laying on the floor and check their blood sugar, it'll be 200, even though a few moments before it was 30. So this happens not infrequently. Now, during this time, remember I said that her heart rate stopped, and this is the tracing that was recorded during that time. So you can see that suddenly her heart stops. Oops, go back. Her heart stops. Now, we learned that if you keep anybody up long enough, you can get this to occur. And how long it is oftentimes depends upon the person. And indeed, one of my fellows calculated that the length of the period your heart stops depends on the anal sphincter tone of the investigator. Now, I didn't know what I was doing in 1988, not that I really do now. So I put her in, what we always do when we don't know what to do is I put her in the hospital. And she was nice enough to pass out wearing a Holter monitor. in front of the nursing station, and you can see that this roughly mimics what we saw during the tilt. This, by the way, is not her heart beating. That's the artifact produced by her hitting the floor. So based on these somewhat fortuitous recordings back in this era, we said we must be getting something close to what's happening in real life. So one would think that when people demonstrate this pattern, that if you could prevent their heart from stopping or slowing down, that a pacemaker would be a really good idea. And indeed, the early research seemed to show this. This was a study we were part of. It's called the North American Vasovagal Pacemaker Study. We enrolled 284 patients. We wanted to look at actually it was time to recurrence of syncope. Sometimes one of the problems is that there is a limited amount of money that you can spend and time you can do. And so you look at the easiest markers to look at to see if you've got success or not, because again, there's plenty of studies you'd want to do, but there's just not unlimited resources to do it. So they looked at time to syncope, and indeed, it looked like there was a tremendous benefit from this. Our Canadian colleagues, by the way, have been the ones that did some of the best research in this field. And indeed, this is part of it. If you see the syncopal rate of people with pacemakers, now, this is sometimes you will see very different ways the data is displayed. For example, in America, we tend to plot how frequently you have syncope. In Europe, you plot syncopal-free interval. In other words, so the scales look backward of each other. This plots cumulative risk of syncope, so you've got to be careful. Sometimes the data, the way it's presented, is very different, but it's saying the same thing. So those with pacemakers had a very low risk of recurrence of syncope. Well, that sounded really good. And indeed, this was another trial that was done called the VASIS trial that did the same thing, where they put pacemakers in people who had these tilt-positive things, and we said, gosh, they do seem to work. And again, here's the same kind of thing. Now again, this is, remember I said this is syncope-free interval, so again, you've got to flip the data around in your mind. So the higher the number, the better. So the pacemaker people do a whole lot better than the people without pacemakers. Well, that looked really good too. This was called the SYNDIT trial. This was a European trial, same kind of thing. And again, people with pacemakers did really well. This again is syncope-free interval, so the higher the number, the better. However, there was concern that we were seeing a placebo effect, and so 2 trials were done where everybody got a pacemaker, and half of them got it turned on and half of them got it turned off, and neither physician nor patient knew who got what. There was a person from the data monitoring thing that would come and do it, and they were followed for a period of time. And in both studies, they saw no difference between the people who had it turned on and turned off. However, there were problems. One, this was a very short trial with a 6-month follow-up time, and most of us thought that was way too short. And in this trial, when they went back through, and they said, and actually they were putting these in anybody who was having neurocardiogenic syncope, they said, you know, if we had really good documentation that they had asystole, particularly if they had recorded it in real-world episodes, like by Holter or monitor of some sort, that group, when you went back through, really did well. But the other people, if you didn't document it, didn't do well. And we became to realize that inducing asystole during a tilt table test was not predictive of what you saw in the real world. It told you a person's system didn't work well, but the exact pattern, since you were doing this under a very artificial situation, could not mimic what was happening in real life. Now, the idea of seeing what's in real life has been the goal of cardiologists for a long time, and if you hear the term Holter monitor, it is named after a person, Norman Holter. That's him. That's the first Holter. It weighed 85 pounds. And that's a motorcycle battery that was powering it on his back. Now, this guy was a genius. By 1964, he got this thing down to 2.8 pounds and began to do the first recordings. And indeed, at that time, you have to realize that it was not if you'd say, doctor, I feel like my heart's racing or skipping or whatever, you would walk into your doctor's office, he would do a 12-lead EKG, it would look okay, and he'd say, you're crazy. And actually, the first paper published by Holter in the Journal of the American Medical Association The title was Documentation of Phantom Arrhythmias. That's what they were called. And basically, he showed that these people were having real arrhythmias because he was able to see them for the first time. Now, the trouble is, if you've never worn one of these, and I have on more than one occasion, due to my own health issues, they are not very comfortable. They are not much of a fashion statement. Most insurance companies will only allow you to do them for a day. In addition, there's a major problem that we run into sometimes with people having allergic reactions to the adhesive, even in the ones that are supposedly hypoallergenic. So the one-day problem was an issue. Then they developed these kind of wearable monitors, which you can wear for prolonged periods of time. On the other hand, there are a number of problems. One, they're oftentimes not put on properly. You have to take them off to shower. I don't think this guy shaves his chest every day to put these on. So that oftentimes you get artifact and get garbage that comes through. In the mid-1990s, another, again, to give credit where credit is due, our colleagues at London, Ontario, and Canada, George Klein and Andrew Cron, helped develop a modified kind of pacemaker. They took the recording circuits out of the pacemaker and put them in a separate device. We were one of the first US centers to implant this in 1995, and basically it's an implantable Holter monitor. That was me holding one of the original ones. These had to be put in through a surgical procedure. Most recently, they have become that small, and now these are literally injected into the skin. So this is the injection tool that's used. The position is roughly here. Actually, we've done research showing it's better to put it somewhere else, but that's a topic of another issue. So I'm about to put one in. You cleanse the area, you prep it here. You make a small incision, insert the device, turn it, and then inject it under the skin. Now what you have now is a 365-day-a-year, 24-hour-a-day, 7-day-a-week Holter monitor. And this device automatically records and stores data, and all you've got a transmitter station, and all you got to do is get within 10 feet of it, and it downloads everything to us, no matter where you are in the world. It uses a special cellular phone frequency. This is a X-ray that shows you what the location is. These are external EKG wires, by the way. It's not in the person. This shows you where it is in relation to the heart. So for the first time, we could watch people in the real world 24 hours a day, 7 days a week, 365 days a year. So to give you an example, this is a 10-year-old that came from Florida to see us. And starting at the age of 1, the child would turn pale, fall to the floor, and have convulsive activity lasting anywhere from 30 seconds to a minute. He had urinary incontinence during the time. He was very confused afterward. He had really bad episodes about 5 to 7 times a year, milder ones about once every couple of months. He had been seen at 4 major medical centers in the United States, and mainly was admitted to neurology, though, and had multiple EKGs, echoes, Holters, EEGs, MRIs, etc. They started to say that these were psychogenic, and indeed they began to accuse the mother of Munchausen's by proxy. He came to us, and we put in one of these devices, and this he had one of the older ones, so it was putting these in small children. I do both peds and adult medicine, and sometimes we'd have to operate on 2-year-olds and put these very large devices in, which was challenging. Anyway, so we put one of these in, sent them back to Florida, and at this time, by the way, you had to download them by phone. So we had a phone link that you downloaded. They didn't have the automatic transmission system invented yet. And the mother called and said, he had a mild episode. It wasn't a real bad one, but he fell, bruised his head, chipped a tooth. I said, well, hang up the phone, set up your transmitter, and send me what the thing recorded. And that's what it recorded. So you can see that his heart just stops. And by the way, that's the beginning of it. That's the rest of it. So he stops for about 25 seconds. That was a mild episode. This was his psychogenic event. So they flew back, and I put a psychogenic pacemaker in him. And he's never had another episode. Now, to show you how this child's life had been affected, and I think it's a good example, this child was not allowed to attend school. The school said, we do not want you here. The state of Florida makes us provide you with an education. It doesn't tell us you have to be in school. We're tired of calling ambulances. He was not allowed to go, attend any sports events. Other parents did not want him over their house. So he basically stayed at home all the time by himself and got very, very depressed. Last time I heard from the mother, which was only about a month or two ago, actually the mother wrote me after she heard about my wife, he is captain of the high school swim team. Now, occasionally you do run into people that are crazy. But that doesn't mean they can't get sick. So this was a woman who was probably one of the most unpleasant patients I've ever encountered. And was just mean and nasty and anyway, and really pissed off everybody. But at the same time, the episode she described sounded pretty real. And I remember one of my mentors, as I was going through my training, once said, "Grubb, squirrels get sick too." So it was easy to think that these might be psychogenic, but I thought, well, let's give this lady the benefit of the doubt, and I will put one of these devices into her, and let's monitor and see what happens. So about 2 months later, she had three different events. I had to cut and paste this to put it all together so that you can see that her heart stops a total of 44 seconds. And actually, this is slow. You can see the P waves here of the upper chambers beating with no lower ones. And indeed, we put a pacemaker in her, and she stopped having her convulsive episodes, but she was just as mean afterward. Didn't help that. So again, to give credit where credit is due, our Canadian colleagues used these devices to what's this called the RAS trial. Andrew Cron is really the principal person. He's currently head of cardiology at British Columbia. And they showed that by using these early, instead of doing all these other tests, you could come to a diagnosis much faster at a much lower cost rate than if you did them as a last resort. Interestingly, a study, this is one of several studies, we also published one as well, showing that this came out of Manchester, England, by Adam Fitzpatrick's group. He's one of the British researchers who's been prominent in this field. And they showed that using this technology, that 40% of patients that were diagnosed with epilepsy actually didn't have epilepsy. They had one of these problems, 40%. So it was very evident that the money does not exist to stick these things in every single person. So we went back through a lot of data and said, well, of the times when we've got something on these, which was about 30% of the time, by the way, so about 70% of the time you don't see something. So we went back through and said, what are the clinical predictors of finding something? In other words, who should we put these in? So we found that if you had a prolonged episode of syncope and loss of consciousness, which we defined as greater than 5 minutes, if you had convulsive activity during the episode, and if you lacked any warning, which we call a prodrome, any of those were predictors of having extremely slow heart rates during your events. So this is another example. This is another kid who was told she had a conversion disorder. And you can see that her heart just stops down here. This is someone who was told they had pseudo seizures, and I guess that's true because they actually were flatlining. And you can see the same kind of thing. So the idea then came into being, well, what if we use these devices as guides to who gets what? And this was called the Issue 2 trial. It basically used these devices to guide therapy, and if you did that, you got very, very good outcomes, and actually most of these people got pacers. But the same question came up, is there a placebo effect? So this was recently published. This was called the Issue 3 trial, and basically it was the same kind of trial as the other ones I mentioned. So they took 511 people and gave them ILRs. 89 ended up with asystole or something close. 77 agreed to be randomized in the study. Everybody got a pacemaker. half of them got it turned on, half of them got it turned off. At 1 year, they were crossed over. So everybody had it on or off for a year, and nobody knew who got what. Okay, so the physician and the patient did not know who got what, and they were followed. And this is an example of some of the things that were included. When you see this wiggly stuff, that means they're convulsing. They're having seizure-like activity. So this is what it showed at the end of the 2-year period for those individuals who had the pacemaker turned on. Now again, this is syncope-free interval, so it's the European way of plotting things. So the higher the number, the better. So there was a 25% recurrence rate as opposed to a 57% recurrence rate. So this definitively proved that if you documented the fact that people were bradycardic out in the real world, using watching real events, and you use that as a guide to pacing, you could get pretty good results. But there was 25% of people that continued to experience syncopal events. Why was that? Well, because during episodes of neurocardiogenic syncope, usually the first thing that happens is they vasodilate all over. And so blood pressure falls first and heart rate falls second. So a traditional pacing device that looks only at rate, by the time it can sense that your rate is dropping, you're already down here. So you're already well into an event. So it comes out being too little too late for some people. So starting in the early 1990s, we began working cooperatively with several research things to develop a pacemaker that could somehow sense blood pressure. Now this was one of the early prototypes we worked on. It was called the Precept. It was made by a company that no longer exists. And it had a special lead that was huge. It was a 9 French lead. It was, the average lead we put in now is 6 French. And it was a special lead. It had 2 different poles. It created an electrical impedance field between these 2 poles. So when the heart was full of blood during diastole, the resistance to current flow was low. And then when it contracted and had a smaller volume, the resistance was high. So we figured that if your blood pressure dropped, there was less blood in here, the impedance would change. And this impedance measurement could be a reflection of blood pressure. This is a paper we published in 1992 using this experimental device that was never marketed. This was an FDA-approved trial. And you can see that in this person who previously had a tilt time of about 2 minutes, 2 seconds, as their blood pressure dropped, the device could sense it and pace faster. And as it paced faster, it could pull the pressure up. So we proved the concept could be valuable. Now, unfortunately, this company did not bring this to market. The patent was acquired by another company, a German company, who then began to develop it and had a greater degree of resources. And in around 2005, right around the time I was sick, the first device was being marketed. And basically, it took the same principle. It uses regular pacing leads, so you don't have to use a special lead. And it creates a continuous electrical field between the tip and the can. And same principle. If the heart is full of blood, the impedance to current flow is low. If it's empty, it's high. And so the device, for the first 12 hours after you put it in, measures every heartbeat. And because it's a sine wave, right? Systole, diastole, measures the impedance change and summates all of them into one beat. So it uses it as a template to measure against. So basically, we have a surrogate measure of blood pressure. So basically, it gives us, it looks at the force of, you could also say it looks at the force of myocardial contraction, and that would be another way you could say the same thing. So would it work? So we looked initially at a group of patients who had recurrent syncope, who had failed everything, including pacing. These were people from around the country. All these people had to wear helmets all the time. They all had multiple fractures and head traumas. And all we did basically is replace their devices with these new devices and actually compare them against a group of people who were getting just conventional pacers, since this was part of a study. So the trademark name for this is called closed-loop pacing. And basically, this shows you the reduction in syncope rate, so that in 84% of these people who nothing else worked, this would work. And interestingly, even if it didn't completely eliminate your episodes, it slowed them down. So all of these people never had any warning, no warning whatsoever, wake up on the floor in a pool of blood. 100% of them got a warning. So even if it wouldn't stop it, it would slow it down enough. Now that is a major deal for these people because they can feel something coming, lay down, and prevent injury. So, so if you look at it a different way, we had a comparison group that got plain old-fashioned pacers. These were here. And we followed them over a period of time, and the success rate, now we had 4 criteria for success, either no syncope, reduction of syncope rate by 50%, if you only felt like you were going to pass out, had pre-syncope and didn't, or if you had no prodrome before and now always got a prodrome, that we had a success rate of 84% in people that were the bottom of the barrel, worst of the worst, no hope left. So we thought, well, that was pretty cool. And we published that here. Now, it didn't take long for the Europeans to catch on to this idea, and they did a study, and they looked at less sick people. And they compared 2 other devices, but basically, this was a comparison. So everybody got pacers, and this was the conventional pacing group. Now, again, this is a European trial, so it's got syncope-free interval, all right? So that the higher the number, the better. These are the people with these blood pressure sensing systems. These are regular pacers. You don't have to be a mathematician to figure there's a difference there. And that was published here. Then a second study was published that showed the exact same thing. Now this was actually, that dotted line here was what happened is the Safety Monitoring Board terminated the placebo end of the trial because at this point they said there was such a dramatic difference between these 2 groups that it was unethical to continue. So we said, well, this looks pretty good. And more recently, we've been publishing some of our follow-up people longer term. We recently published a follow-up study. This is a little bit of addition to that, and I was trying to go through the data to update it for this conference, but actually I didn't finish it all because life has been difficult. Anyway, so of 175 patients that we looked at who received this device, we had 115 women, 17 men. The mean number of syncopal episodes in the 6 months prior to implant was 5. 54 of these had suffered severe trauma, including skull fractures, concussions, jaw fractures, fracture of the arm or leg, and 6 had cerebral hemorrhages due to falls. Over a mean follow-up time of 18 months, we had a same thing, 82% response rate. Now, you might say, well, why do the Europeans get a higher rate? They don't put it in less sick people. They basically have been implanting these in people who don't fail everything. And the responder character, so when we look back and we said, of these 82%, what predicted good response rates from it? Well, the people who had prolonged asystole that was documented prior to their implant, convulsive activity, a history of injury, prolonged loss of consciousness, and lack of prodrome. So the exact same things that we saw before. But one of the things I think to keep in mind is this breakdown that we've made into different types of autonomic problems was not handed to Moses at Sinai. These are categories we made up to try to understand this better, and they overlap. They're not like pure. So for example, we began to notice that when we would tilt some of the POTS patients, particularly those who reported to us that they had recurrent syncope, that they would do this. Okay, this is during a tilt table test of a patient with POTS. Initially, they got very tachycardic, suddenly slowed down, and went into asystole. I thought, well, that's pretty interesting, but I don't really know, as we said, that this could be an artifact of just the way we're doing the test. So maybe we should start putting in some of the patients who either display this pattern during their POTS patients who display this pattern during their tilt, or alternatively, tell us all those things we said before, that I pass out without warning, I have prolonged loss of consciousness, I have convulsive activity. Maybe we should look and see what they have. So we started doing that. So this is an example of a young woman, classical POTS patient, late teens, recurrent episodes of syncope, had convulsive activity during them, would be incontinent, would urinate all over herself during it, would have prolonged recovery times, but had all the in clinic had all the classic characteristics of POTS. So we put one of these devices in her and monitored her, and then this is her prior leading up to it. So this, when you have an event, it automatically records it, but it also looks back in time. It always has 5 minutes worth of data in it. So she's tacking along at around 110. But then suddenly, this is what she does. She starts slowing down, stops, has one or so beat, and then really stops. Okay? So this is a real world event that we witnessed, that she had nothing, she didn't have to record anything, do anything. This did it all by itself. There's no way you can fake this data, unless you want to take a penknife and cut it out of your chest. And indeed, with pacing, her syncopal episodes disappeared. Her other symptoms did not. Okay, the fatigue, some of the other stuff didn't. So just the syncope got better. That's it. I had a fellow trying to get this together for this conference, and I was not able to get the data together in time to actually give you numbers. But what we've so far seen, our estimate is about 20 to 25 POTS patients who have this recurrent syncope with no prodrome, prolonged loss of consciousness, convulsive activity, can have significant bradycardia. We've also seen a group of people who will develop what's called chronotropic incompetence, which is somehow as the illness progresses, they lose the ability to control heart rate as well, and they get a flat heart rate response. In other words, so that when you sit there and do nothing, your heart rate should be like 60. But if you get up and walk around and do stuff, it should go up to 90, 95. And these people don't do that. Now, if you go back to and think about the autonomic failure patients, we see more and more people, say with Parkinson's disease, who have autonomic failure, and they develop this chronotropic incompetence pattern where they get up and walk around and their heart rate just stays at 60. And we have a study we're about to publish showing that this technology in them can also be helpful as well. So does it work in everybody? No. It works in a select group of people. And do we pace everybody? No. We pace people where we have documented evidence that it will help them. So these overlap. These are not pure groups. Again, we are imposing our will upon nature. Stephen Hawking, the famous physicist, once said, the universe is analog, not digital. Now, I just wanted to briefly share with you something else that I've been working on. As someone who works with children a lot and also with young people, oftentimes they would have problems with scarring. Initially, when I was trained in surgery 30 years ago, we didn't care much about what things looked like. Also, the infection rate in the US for these devices is climbing at a dramatic rate. It currently is estimated that up to 6 to 9% of all implantable devices will become infected. Infections oftentimes lead to severe sepsis and death. You have to extract it. During an extraction of a chronic device, you have a 5% chance of dying on the table. I did an extraction on Wednesday before I came here, and came the closest I've ever had to losing somebody on the table, because literally the heart can just rip open as you're taking these out. So the plastics dealt with some of these issues with breast implants and expanders. And so I went back to being an intern for a while, which was sort of a humbling experience, and relearned plastic surgery techniques. I would be there at 6 a.m. every Thursday. And with it, the idea was to perhaps take their ideas and develop a new way of closing wounds that would not only be cosmetically better, but would reduce infection rates. And after much experimentation, we came up with a new methodology for closure. This was an approved study that we did as I said, the infection rates continue to go up, partially because there's more and more resistant organisms. And also, I think people aren't as well trained as this may sound like some old guy ranting and raving, but people aren't, at least electrophysiologists are not trained in surgical technique as meticulously as in the past. They're more focused on ablation and things. So the technique, this is me operating with one of the fellows. So we do, I won't go into all the details, but basically we do a three-layer closure. This is a final layer closure of the skin. This is what we've developed. We've called it a buried knot technique. You take a synthetic, there's a synthetic material called biosin, which is a monofilament. Previously, many sutures were polyfilament. They were braided like rope, and it was felt that that braiding could hide germs and things. So this is easier to sterilize. And you come from deep within the wound. You come up through the wound like this. By the way, my daughter made these drawings. So you come up through the wound like this. You then turn around and go the other way. Come in like this. Oops, sorry. Come in downward like this. And so this comes out. So both ends of the suture are deep within the wound. And again, an illustration is like this. And then you tie it, and this way the knot is below the wound surface. And then so you pull it up, cut it, and then the knot retracts under the surface. So these are each individual stitches. This is a tedious technique. It takes a while to do. But basically you have individual sutures that are below the skin surface, so there's nothing touching the surface. Because the plastics people found that all infections start on the outside and work inside. So with this, the knot's down here. Now you have to put like 20 to 25 of these in. Oftentimes you have to use a magnifying loupe to be able to see what you're doing, because you have to use extremely small suture material, and it's extremely tedious. And my former colleagues, none of them wanted to learn how to do this because it takes an additional like 20 or 30 minutes to do. So then you, as I said, you pull it up, cut it, and the knot retracts under the skin. When you're done, this doesn't project well, but you can see that it's a very tight line. And then we close this with surgical glue. And the surgical glue serves as the final layer of sutures, but also serves as a waterproof barrier that it does not allow infection to get in. And then it's covered with a nonstick pad, and these are called Telfa pads, Tegaderm pads rather, that serve as another barrier to infection. So it's covered like this. So we have multiple barriers to infection. And the prep material that we scrub the chest with is left there. So that antibiotic solution that we scrub the chest with is trapped under that plastic dressing. So the plastic dressing is a barrier, the glue is a barrier, and the sutures are a barrier. And you can't, this is what the scar looks like at about a month afterward. So basically we can achieve the same results as plastic surgery during their closures. So what about infection rates? So we looked at this, we published 2 papers so far. We looked at, there were included who got this technique over time. I did 313 patients. I was the only one doing this technique. My colleagues chose not to. This was the breakdown, 118 males, females, and these were a combination of loop recorders, pacemakers, defibrillators, and biventricular defibrillator systems. Follow-up was anywhere between 1 year and 69 months. We had 3 problems. We had 1 case of wound dehiscence, which we decided to exclude because this person had had a heavy radiation to the chest. Once your chest has been radiated, it may never heal properly again. It's one of the characteristics of having received heavy-duty radiation. We had 1 person who had an allergic reaction to the metal in the device, and so we decided to exclude those. So we had 1 infection. And this was a E. coli infection, which is an organism that lives in the bowel, and we think that the guy got it in his bloodstream. So I'm not even sure this was a real one, but I decided to be a good scientist and include it. So my colleagues during that time, who none of whom are still at our institution, this was 313 patients, and then so I compared it to my colleagues who did 383 patients. And during that same period of time, using standard closure techniques, and they're competent surgeons, there were 23 infections, 14 for ICDs, 9 pacers, 12 within the first month. Now, if you have an infection in the first 90 days, Medicare will pay nothing for any of it, by the way. That's what people keep looking at. So the infection rate was about the national average, which was 6%. So it wasn't like they were doing bad stuff. But the infection rate for this closure technique is 3.3% during the same time period, roughly the same number of cases. So these are several papers that have been published. This is the most recent one, and a more recent one has suggested it may be as high as 9% compared to our data from 2 papers we published, which stays at 0.3%. So if you look at the cost of these, just the can, forget everything else, for a biventricular defibrillator is $40,000. Okay, just that can. Not including the leads, not including the surgical time, not including anything else, just the can. So when you take that out after a month, you just threw, like 80 grand down the toilet. And the hospital, when it reimplants it, gets paid nothing by Medicare, 0. So if you look at the cost savings, the potential cost savings, this is what it costs the United States each year in infections for devices. So this is the potential cost savings that we can have if people would adopt this technique. Now, this has been a uphill battle trying to teach people anything new. God forbid you learn something new. So I'd like to thank you for the opportunity to be here. It's been a great honor and pleasure. I'm truly honored that you chose me to be your Physician of the Year. Can I answer any questions for anyone? Or do we have time for questions?
We do have 5 minutes.
Okay.
If someone is diagnosed with a seizure disorder and is on seizure medication and it supposedly stops it, is that different from this?
Yeah, no, there are people with true seizures. By the way, so as a different track and a study that we're trying to get going that other people are doing, for people with true epilepsy, true seizures, true epilepsy, their sudden death rate is 6 times higher than the general population. 6 times higher. And there have been several studies where people have been wearing Holters or in the hospital, and it turns out that once the seizure begins, it's an electrical storm in the brain, and it can spread to the brain stem where your autonomic control centers are. And so there have been recordings of people in the hospital who have had seizures while being monitored. The seizure begins first, and then their heart stops, or they go into ventricular fibrillation. So a pilot study that was published in the British journal Lancet put loop recorders in a group of people that had what sounded like near-death episodes, who had epilepsy. Look at John Travolta's son died, and what they saw is during their seizure, and no one argued that they had a real seizure, their heart would stop for prolonged periods of, potentially lethal periods of time. And you can see that the seizure began before the heart rhythm did, because you can see that artifact I mentioned. Now notice the one I showed you, it was after the person flatlined, you saw that artifact suggesting a seizure. In these other studies, you see you see that coming first, and then you see them go flatline, or they go into ventricular fibrillation. There's a gentleman named Oppenheimer at the Johns Hopkins Hospital who's done a series of experiments with dogs where he's taken them and actually induced an electrical seizure mechanically and in normal, healthy dogs, and what he's been able to do is fibrillate their hearts, make them die with nothing wrong with their heart. Nothing wrong with their heart. So part of the etiology of this high rate of sudden death in epileptic patients may be that the seizure provokes heart rhythm problems. And so it's been a little tough going to try to get the neurologists to cooperate with us. But many of us would like to do a trial where in the very, very severe seizure patients that we put these devices in, and they're good for 3 years. We got 3 years worth of continuous monitoring, and look at how often this phenomenon is happening. I went to a recent meeting where they showed from Jefferson, where there was an unfortunate young woman who died in the epilepsy monitoring unit. And you could see that the seizure began first, and then she fibrillated. And unfortunately, the response time was not terribly brisk. And she was unable to be resuscitated. But it was very but now this is someone who's got an EEG on, in addition to monitoring their heart rate, and there's a video camera recording it, so that you could see that the seizure became first. There's no question that occurred. So again, I think there's overlaps here. We like to divide the world, into black and white and things like that. And in reality, I was going to say it's shades of gray, but that has a different meaning now. Things are not, there are blurred boundaries between things, and things are not like, yes, no, black, white. As I said, the universe is analog, it's not digital. Probably most of you younger people don't even know what analog means, but.
The inclusion for the issue trial, did you have to prove asystole, or is it
Yes,
a lot of
for the issue 3 trial, you had to have asystole for greater than 4 seconds. Now, again, you have to realize when you're doing research, you have to use relatively rigid criteria, for things, and then you can begin to look at other things. So we have found, by the way, that people have relative bradycardia. I mean, so if your heart rate drops to 30, when your blood pressure is 70, that's pretty much the same. And we've shown that those individuals it's just like they're asystolic, and they get the same response patterns. But the issue 3 trial, we had to prove the point, and we wanted people where nobody would question, where there was no question that they had a problem, and there were no question that they were all the same, you know what I mean? Where we made everything the same except for pacing on and off. And by the way, there's going to be, we are soon going to be part of an issue 4 trial, which is going to compare CLS pacing, that pressure sensing thing, because you can turn that circuit on or off in the same pacer. In other words, it's a function you can turn on or off. And so we're going to do, the plan is to do the same thing. Half the people get to turn on, half of them get turned off. They go a year and they're crossed over, and nobody knows who's going to get what, so we can prove the point. This, there's a lot of good circumstantial evidence, but this will be a double-blind trial to prove whether or not it works better. Again, thank you.